Oh,
Good morning, everyone. Buenos dias, good afternoon, buenas tardes, good evening, buenas noches. Wherever in the world you're looking at us, it's a pleasure to be here with you once again from Florida International University. I'm Francisco Becerra, advisor to the Global Health Consortium at Florida International University. Today, we're going to have an amazing and very exciting panel, starting with three keynote speakers, and then we will move to a discussion panel where we're going to be discussing the global challenge of COVID-19 vaccination efforts. And I think that is going to be interesting for all of us now that vaccines are being rolled out to the world. And I think that this is something that it gives a lot of hope. It also has bringing issues about equity and inequalities in access to the vaccine. But we're going to be seeing a lot of interesting things and a lot of interesting messages from our speakers. We're going to start with the keynote speakers. And today, the first keynote speaker is Dr. Peter Hutz. He is an American scientist, pediatrician, advocate in the fields of global health, vaccinology, and neglected tropical diseases control. He serves as the founding dean of the National School of Tropical Medicine, professor of pediatrics and molecular biology and microbiology at the Baylor College of Medicine, where he is also director of the Texas Children's Hospital Center for Vaccine Development and the Texas Children's Hospital Endowed Chair in Tropical Pediatrics and University Professor of Biology at the Baylor University. Dr. Hutz has served previously as president of the American Society of Tropical Medicine and Hygiene and is a founding editor-in-chief of PLOL Plus Neglected Tropical Diseases. He's also the co-director of Parasites Without Borders, a global nonprofit organization with a focus on those suffering from parasitic diseases in subtropical environments. With all this amazing experience and knowledge about vaccines, I'm happy to welcome Dr. Hutz. And Dr. Hutz, the screen is yours. We don't have the floor, but the screen is yours today. Thank you.
Well, thank you. Thank you so much for the opportunity to address this amazing conference, and congratulations to the organizers. What I'll do is give a brief overview of where I see the world heading for in terms of COVID-19 and COVID-19 vaccines, as well as our work on vaccines and going up against what's becoming a lot of anti-science, anti-vaccine aggression, and which is something I don't think any of us would have anticipated in our 2020 year of COVID-19, and now moving into 2021. So I'm going to give kind of a high-level overview, and I'll be curious to hear everybody's thoughts about this. And let me start here. Can people see my slides? Yes, good, fantastic. So I'm going to start here by, telling to begin with some good news. And the good news, of course, is that overall global governance for vaccines and immunizations has been effective. This is our under 5 deaths from childhood infectious diseases. And you can see that we've made tremendous gains in terms of our ability to vaccinate the world's children. This was initially launched with $750 million of Gates Foundation support to form the Gavi Alliance, which I consider really one of the most successful global health initiatives ever, a partnership with the World Health Organization and PAHO and UNICEF and the World Bank, and of course the pharma companies and academia. And these are the new results coming out of the Global Burden of Disease study led by Chris Murray and the Institute for Health Metrics. So many of you when you think of the Institute for Health Metrics and Evaluation, you think of their appearances on CNN with regard to COVID-19. Well, they were actually set up to monitor the impact of all these big global health programs. And you can see tremendous progress, big declines in the number of kids dying from measles and pertussis or whooping cough and tetanus and diphtheria and meningitis. And this is one of the real triumphs. By the way, the pictures on the right are some of my favorite black and white images from Brazilian photographer Sebastiao Salgado. And I first saw these more than a decade ago. PAHO, in their lobby in their headquarters in Washington, D.C., displayed many of his black and white images. And you should Google them. They're very moving because he spent time going around the world photographing kids getting their vaccines, mostly their polio vaccines. And I love the expression on the parents' faces, the full range of human emotion from hope to joy to fear to bewilderment. I find them a very moving set of images, and I look at them for a source of inspiration. And I first saw them at PAHO headquarters many years ago when they did that event. I have a new book coming out called Preventing the Next Pandemic: Vaccine Diplomacy in a Time of Anti-Science. And it's just coming out now. It's now available, published by Johns Hopkins University Press. And I make the case that despite all of these amazing gains, we have seen a slowing or a halting or even a reversal of our gains in some parts of the world. And they're happening because of things that, as biomedical scientists, as physicians and scientists, we're ordinarily not trained to think about. It's happening because of poverty and war and political instability and urbanization and deforestation and climate change and this rise in anti-science. Now there's some dialogue coming up about the role of climate change, but my premise is it's not just climate change alone. It's climate change acting in collaboration or in synergy with these other social determinants. So the book begins by identifying some tough parts of the world where we've seen a sharp return to disease and unraveling, where we've had gains. And I said it's this ways, and it happens in places where political instability combines with climate change or urbanization or deforestation or anti-science in these very unique and interesting ways. So for instance, on the Arabian Peninsula, and a lot of these changes began starting around 2013, 2014, 2015. So the unraveling is relatively recent. So for instance, in the Arabian Peninsula, where you had the Syrian conflict starting, the civil war starting in 2011, 2012. Then you had the ISIS occupation in Syria and Iraq and starting in 2014, 2015. And then the proxy war between Iran and Saudi Arabia that started in Yemen. We've seen collapse of health system infrastructures and return of cholera and cutaneous leishmaniasis and vaccine preventable diseases, including measles and polio. And it's not only war and political instability. We also had unprecedented temperatures at 50 degrees Celsius, drying up ancient agricultural lands along the Tigris and Euphrates, and causing people to abandon agricultural lands, pile into cities like Aleppo. And some believe that desperation for water resources may have fueled a lot of the conflict. So it really details how in these very interrelated ways these forces combine to bring back disease. Or in Africa, what Jeffrey Gettleman of the New York Times calls Africa's unwars, because it's not wars between warring factions, but armed banditry on civilian populations, bringing back polio and measles in the Boko Haram areas of Nigeria, as well as sleeping sickness and Kala-Azar, or in Central Latin America and Venezuela with the socioeconomic collapse there that followed 40 years of drought, that through the political instability and aggressive urbanization and deforestation, once again, we've brought back measles and other vaccine preventable diseases, people desperate for employment, sleeping in the illegal gold mining and illegal gold mines without bed nets, exposed to malaria, people fleeing the country, fleeing Venezuela across the border into the Amazon region of Brazil, where they're coming into contact with indigenous groups like the Yanomami, causing decimation due to measles and now COVID, or going the other way across into Colombia, coming in contact with the Wayu indigenous people. Again, how all of these combine in unique and interesting ways. I even have Texas and the Gulf Coast here. Not so much political instability, although part of that, but also Texas and the Gulf Coast is the epicenter for climate change in North America, together with aggressive urbanization and these rise in anti-science forces that first arose out of Texas. And so that when we talk about COVID-19, my premise is COVID-19 is not something completely new or different. It's really the culmination of an unraveling that began 5, 6, or 7 years before. And when you look at where COVID is happening, it is interesting. So far, it is not swept through the African continent, although we're worried now with the South African variant. That may be the case, but it's mostly in wealthy countries, G20 countries. But it's the poor, people living in poor neighborhoods or low-income neighborhoods in G20 countries that are mostly affected in the United States and Brazil and South Africa and India. Again, G20 nations, the 20 wealthiest economies. And this concept of the poor living among the wealthy is not unique to COVID-19. We've seen this now with tuberculosis and dengue and leishmaniasis and Chagas disease and parasitic worm infections. The point is it's the poor living among the wealthy that kind of represent the new global health. So this traditional norms of global health, where we talk about wealthy countries versus poor countries or global north versus global south, is giving away to the poor among the wealthy. And I've given this the name Blue Marble Health to kind of brand it in a different way. And there's a new book that I also have that just came out for free on Johns Hopkins Project Muse in the upper right corner, called Poverty and the Impact of COVID-19, the Blue Marble Health Approach, where you can look at that in more detail. And when we look at how we're going to vaccinate against COVID-19, we've done work over the last decade to show that the spike protein of the coronavirus is the soft target for the virus. So these little flowers on the lower right-hand side are actual images of the coronavirus with faux color imaging, and you can see these trimeric spike proteins emanating out, and this is what docks with the host receptor, the angiotensin converting enzyme 2 receptor, to allow the virus to go into the cell and replicate. And what we showed over the last decade is that if you can halt this, if you can induce strong virus neutralizing antibodies against the spike protein, and that provides the basis for all of the coronavirus vaccines, COVID-19 vaccines that we have today. All of them work in different ways, but with the same goal, to deliver the virus neutralizing antibodies against the spike protein. And I tell you this, that we've been doing this R&D program for 10 years for the simple reason that one of the major tenets of the anti-vaccine groups against COVID-19 is they say, don't trust these vaccines. They just appeared out of nowhere over a period of a few weeks. And my premise is, well, no, that's not true. The COVID-19 development program was a 10-year program like any other vaccine program. It's just what happened was the pharma CEOs, when they would release send out their press releases, they're not talking for you or for me, they're talking for their shareholders, and they tended to spectacularize their contribution, ignoring the 10 years of research that our group did and many other coronavirus groups did. But that's unfortunate, because the consequence of that is to cause a lot of people to distrust vaccines. But they all work, whether it's a nanoparticle vaccine or a recombinant protein vaccine like ours at Baylor and Texas Children's, or the Johnson & Johnson vaccine, or the AstraZeneca vaccine through adenovirus, or through Moderna and Pfizer, through mRNA, or Inovio through DNA. They're all working by delivering the spike protein in one way or another. And the consequence of inducing virus neutralizing antibodies is that's what's going to keep you out of the hospital, out of the intensive care unit, the ICU, and prevent you from dying. And that's the major goal of vaccination. But the good news is we now have some additional evidence that these vaccines may stop transmission. So yesterday, in the New England Journal of Medicine, a group from Israel reported that 2 doses of the Pfizer-BioNTech vaccine will reduce asymptomatic infection by 92%. And the reason that happens is because if you get high enough levels of that virus neutralizing antibody, it can cross over into the mucosa and the mucous membranes and stop virus shedding in the mouth, nose, and throat. And we showed this with our vaccine as well as others. And that's the basis for halting asymptomatic transmission. And the reason this is important is if the other vaccines do the same, it means that if we get high enough vaccine coverage, and we did a study with Bruce Lee at the City University of New York Public Health School, to show that if we get high enough coverage, we can actually halt virus transmission. And that means, as we, in the United States anyway, as we move into the summer, fall, potentially we can go without masks and reduce some of the social distancing constraints. So that's pretty exciting if that happens. We're not there yet. We don't have the full evidence base yet, but I think we're heading in that direction. It is interesting that the CDC has now said, our CDC in the US has said that we no longer need to quarantine if we're fully vaccinated. And I think that's because they're pivoting in this direction. I think to get to that high level of coverage, we'll need several vaccines. The mRNA vaccines alone will not be adequate. We'll need at least 5 or 6 vaccines. We'll need to vaccinate adolescents and children. I don't think we can rely on only vaccinating the adult population. And we're going to have to step up our game in terms of public communications and halting the anti-vaccine movement. So this is what it looks like in the US. Those first wave of vaccines was the 2 mRNA vaccines from Moderna and Pfizer. And then the second wave is starting now in 2021. We'll probably get authorization under emergency use for the J&J adenovirus vaccine next week, and hopefully the protein particle vaccine from Novavax will follow, and the adenovirus from AstraZeneca. And then we have a third wave of vaccines, which I'll talk about in a minute, a recombinant protein vaccine that's combined with Baylor and Biological E, based in Hyderabad in India. The question I'm often asked is, hey, doc, which one are you going to wait for? Which one are you going to take? And I wound up taking the Pfizer-BioNTech vaccine, but I say, look, don't wait. They all work the same way. They all work by inducing virus-neutralizing antibodies. What we don't know for any of them is what the durability of protection is. Will they last 3 months, 3 years, 30 years? We won't know till we know. And so recognize that there's a likelihood you're going to be immunized with a third dose at some time in the fall or starting next year. And part of that reflects the fact that we have to worry about these new variants, which go by either the names of variants of concern, VOCs, or the less memorable spike gene target failure variants, SGTF variants. And the initial ones that seem to be rising very quickly are due to an aromatic amino acid substitution in the 501 position, where you're getting a tyrosine coming in instead of a different amino acid. And that tyrosine, what it's doing is it has an additional hydrogen bond with its the host ACE2 receptor, and there's a ring-ring interaction to cause tighter binding, and that's translating into higher transmissibility coming out of South Africa and the UK, and also in the case of the UK, the government's reporting, although this has not yet been peer-reviewed, that it's leading to higher mortality as well. And so we'll see if that's borne out. So this is causing a lot of concern about the next wave of the pandemic. So the numbers are going down in the US. We've went from 250,000 new cases a day to 50,000 new cases, an 80% decrease, and everyone's sort of being very self-congratulatory, but I'm quite worried now that these new variants are going to come through in a big way. Let me just go through this in a little more detail. This is what the UK variant, or the B117 variant, looks like. Let me orient you. This is the trimeric structure of the spike protein, and the trimer has 3 receptor binding domains, and what happens is one of them flips up like a flip-top lid to bind with the one of the 3 to bind with the ACE2 receptor, and that mutation in the B117 variant from the UK is that aromatic amino acid substitution that's causing tighter binding. The good news is all of the vaccines to the original strain so far seem to work equally well to the UK strain. So for instance, the high rate of coverage and success in Israel was done despite the high rates of the UK strain. The greater problem from a vaccine point of view is the South African variant has an additional mutation in the 484 position, which is to a lysine, which is causing a positive charged amino acid at normal pH that is causing an electrostatic interaction that's causing much tighter binding. And here, the level of virus neutralizing antibody goes down. And so I believe the way it's going to turn out is those vaccines that induce very high levels of virus neutralizing antibody to begin with will start having decreases in the level of virus neutralizing antibody. But if you start out at high enough level, there's still enough residual there to protect. It's the vaccines that induce low levels of virus neutralizing antibody that will no longer protect against the South African variant. So here are the levels of protection with Pfizer, Moderna, Novavax, J&J, AstraZeneca, Oxford, all working pretty well against the original variants, but versus ZA from South Africa, there is a significant decline. I think these will still work against the South African variant, and we know in some cases they actually do, like Novavax and J&J with reduced protection, but the AstraZeneca Oxford vaccine, which starts with a relatively low level of virus neutralizing antibody, doesn't seem to protect much at all against South Africa. So that's maybe against serious infection, but we'll have to see. But the point is the Russian Gamaleya vaccine also starts with a low level of virus neutralizing antibody. So I'm worried that's not going to protect against the South African variant. Same with two of the Chinese vaccines, the Sinovac inactivated virus vaccine and the CanSino Bio adenovirus vaccine. So now a number of us are scrambling to say, okay, how do we manage this? Do we now develop new bivalent vaccines with the original combined with the South African variant? Or do we proceed with vaccinating with the original and then boost with the South African equivalent? And I think most of us are leaning to that second direction, which brings us to the problem of the world's low and middle income countries, because we're starting to realize now that we don't have a lot of options out there. The two mRNA vaccines are probably not going to filter to the low and middle income countries in a significant way because of the difficulty in scaling production and the onerous visa requirements. Eventually, we will work that out. And I think in 5 years from now, you could have an mRNA vaccine that's easy to scale and could be kept maybe even at room temperature, but not for now, not for this epidemic for 2020 or 2021. So what do we have? Well, you have the AstraZeneca Oxford vaccine that's great in terms of scalability and delivery, but if the South African variant really takes hold, that's going to be problematic. So there's going to have to be some kind of boost involved. The J&J vaccine, we're having some problems with production, so we'll have to see about that. The Russian and the Chinese vaccines are uncertain quality and so far have not been going through stringent regulatory authorities, as they're called by the WHO or by WHO pre-qualification. Merck is out. They're not in this. Sanofi Pasteur is delayed.
2 minutes.
So we don't have a lot that's really out there. So what we're doing now is looking at producing a low cost coronavirus vaccine that could be scaled for production. And this is a recombinant protein vaccine in collaboration with PATH that works with the Gates Foundation and Biological E, one of the big producers in Hyderabad. And it's a receptor binding domain protein. And we're now gives high levels of virus neutralizing antibody. We're scaling up production of this to produce 1.2 billion doses, testing in 5 sites in India. It's the receptor binding domain produced in Pichia pastoris on alum, together with CpG from an immunostimulant from Dynavax. This was developed at Texas Children's, and one of the great things about it, now that it's being produced, we've got to come up with a more user-friendly name, is in Hyderabad they're producing 1.2 billion doses. It's refrigerated at 4 degrees, and it's the same technology used to produce the recombinant hepatitis B vaccine, for which there's a 40-year track record for, and it's potentially suitable for children and infants because it's been used for 40 years. And they can do this for $1.50 a dose. So it's probably the least expensive of the COVID-19 vaccines. So we're moving forward on this, and I hope we can fill an important gap. And unfortunately, my time's up. But the other big activity that I'm involved with, and maybe we could talk about this at the Q&A or the panel, is that we're now fighting another problem. The reason why so many Americans in the U.S. died from COVID-19, 500,000, is not only due to the virus, the SARS coronavirus type 2, but this political defiance around masks, vaccines, and contact tracing. And now we're dealing with an anti-science empire that started out of Texas in the US. And because I'm a vaccine scientist in Texas, and I have a daughter with autism and have written this book, Vaccines Did Not Cause Rachel's Autism, that's kind of put me front and center of this very aggressive anti-vaccine movement, and which is now a full-on globalized anti-science movement extending into Russia and Western Europe. And how we deal with this is going to be very important, because it's not only going to be about making vaccines, but how we're going to diffuse this very aggressive anti-science empire. So I don't know if my time's up. I guess it is. And
Yes,
and then I'll stop and look forward to the panel discussion. Thank you so much.
Thank you so much, Dr. Hutz. I think that you set the scene on a lot of interesting issues, and I know we're getting some exciting questions for the panel. Let's move forward now from Texas. We go all the way to Europe, and we're gonna be meeting with Dr. Annalise Wilder-Smith, who is a professor of emerging infectious diseases at the London School of Hygiene and Tropical Medicine, and a visiting professor at the Lee Kong Chiang School of Medicine in Singapore. She's also a consultant for the Initiative of Vaccine Research at the World Health Organization in Geneva, and is a member of the SAGE working group on COVID-19 vaccines. SAGE is this advisory group, Global Health Advisory Group for Vaccines in WHO. She's in the past president of the International Society of Travel Medicine and past president of the Asia Pacific Society of Travel Medicine. She has published about 280 scientific papers, books, chapters, and she is very active in research. She has received several awards. Among them is the Myron Levine Vaccinology Prize, the Honor Group Award for Exemplary Leadership and Coordination in Determining and Communicating Global Yellow Fever Risk, presented at the CDC Award Ceremony, the Mercator Professorship Award by the German Research Foundation, and the Ashdown Oration Award by the Australian College of Travel Medicine. She's the principal investigator of a European Union-funded international consortium called Zika Plan, and recently completed another 4-year research project on dengue, also funded by the European Union through the European Commission. And she has been very active in research and her interest in vaccines, and is extremely well known. So, Doctor, let's go to Europe, and give you the screen for you to present. So thank you so much for joining us today, Dr. Wilder-Smith. Please go ahead.
Yes, thank you so much for your kind introduction. Can you confirm that you can see my slides?
Yes.
Thank you. So despite the unprecedented speed of development of COVID-19 vaccines, the reality remains the vaccine supply at this point in time is very limited. So the question now is how best to maximize the use of vaccines if we only have limited supply. And so deploying vaccines equitably has two angles. One is equitable distribution within countries, and the other one is equitable distribution between countries. So within a country, on the left side, we need to prioritize those groups and populations at highest risk of death. So with limited supply, we need the primary objective is to directly protect populations at highest risk rather than indirectly protecting them through herd immunity. For herd immunity, we need higher vaccine coverage rates, which is currently not possible due to limited supply. So within a country, there are basically three populations at higher risk. Those populations with higher mortality and serious morbidity because of underlying medical conditions, those who cannot really stop social distancing because they are exposed due to professional exposure, frontline workers, in particular healthcare workers. And then, of course, there's the last group that is contributing to the high transmission. So it's the high transmission risk population. On the right side, you see what is happening. The inequitable distribution between countries. And so just for terms of terminology, what on the left, we call it prioritization. On the right, within WHO, we usually use the term allocation. So here are the two key documents for guiding country decision. So one was then on a framework on allocation, and another one is a roadmap that we published on prioritization. So let's look at the prioritization, which really started with a values framework. So before we had vaccines, so many months ago, we engaged with philosophers and ethicists to think about the 6 core principles: human well-being, not only to protect our health, but also our social and economic security, human rights, civil liberties, and we also stressed child development. Equal respect, recognizing and treating all humans as having equal moral status and their interests as deserving of equal moral consideration. And then, of course, there's global and national equity, so between and within countries to ensure equitable distribution. Reciprocity refers to honoring obligations to those individuals or groups within countries who bear significant additional risks and burdens of COVID for the benefit of the society. And then legitimacy is really making sure that global decisions about vaccine allocation and even national decisions about vaccine prioritization are done through transparent processes that are based on shared values, best available scientific evidence, and appropriate representation and input by affected parties. So we align these 6 core values with 11 public health objectives. And it's, again, I say it's so important to think through these issues before any vaccine is available, also so that we can hold ourselves accountable. And I think this is now our turn. We need to hold ourselves accountable. Are we applying those principles? So the world's population is currently about 7.7 billion, of which about 2 billion are children, of whom we know they are at low risk. So if you now look at the populations at high risk, and remember the 3, it's the clinically higher risk, it's the higher risk of exposure, essential workers, frontline workers, and it's those that have a higher transmission population. So if you just look, for example, at people working in health and social care, that's already 136 million people globally. If you look at persons above the age of 65 globally, that is already 703 million persons. So you can see, if you look at these numbers, with the current limited supply, we cannot even achieve a coverage of the high-risk target populations. So that's why we had to think even and narrow down and hone down even further. And so this is why we came up with the roadmap of prioritization that is really meant for prioritization within countries to guide countries, help make decisions with a limited supply. So stage 1 is very limited supply, it's below 10%. And remember that even the older age above 65 in most countries is already more than 20%. And so in stage 1, we have the initial focus on healthcare workers and on focusing on older adults. This is this approach that has been adopted basically by all countries. Stage 2 then covers persons who have medical risks that put them at significantly higher risk of severe disease. But it also, then this is important in the context of equity, it also includes those socio-demographic groups that are at significantly increased risk of exposure or of severe disease. And often these subpopulations are associated with a socio-demographic status that also is associated with less access to appropriate care, or even higher proportion of certain comorbidities. And these social demographic groups also include people living in settings that are associated with high population densities, like refugee settings, prisons, detention camps, and also any other settings where persons have to continue to work, where physical distancing is not possible, police, food supply, etc. And then we have stage 3, where we go beyond the 20%. So how do we get even to 20% though? So, and therefore, and this problem was acknowledged very early on in the pandemic. So you all recall 30th of January was the declaration of the public health emergency. By April, ACTA was launched with pledging events and with increasing amounts of financing. And really the core of ACTA, the pillar that really looks at vaccines, is called Kovac. By now, far more than 190 countries have joined Kovac. This amounts to almost 6.8 billion of the population. So really, it is the majority. So this is impressive. The Kovac goals are to end the acute phase of the pandemic by the end of 2021, by delivering 2 billion doses by the end of 2021, and to guarantee fair and equitable access for all participating countries. And basically, this is a huge portfolio. It's also a risk-sharing mechanism, because we all share the risk by early investing in vaccines, some of which may fail, and really is managing the largest portfolio of vaccines globally. So at its core, the facility is risk sharing, but also helps us secure access, and also helps to reduce the risk of the manufacturers themselves. So all countries are invited to participate, and all countries will receive access, and with a pre-negotiated price. And so the Kovac advanced marketing commitment is very important in demanding guaranteed volumes. And then there's also a mechanism to help support low-income or low to middle-income countries that are then supported through overseas development funding. So this is the Kovac facility, and the Kovac facility now deals with allocation. So allocation is the term we use if it's between countries. Within countries, it's prioritization. So the allocation framework that was developed through Kovac really tries to ensure the distribution of the vaccines proportional to the population size, starting initially with very small tranches. And initially, we even thought we could manage 3%. We now know it will be far lower, the initial supplies, than 3%. But the idea is to incrementally increase. So initially give 3%, that will definitely cover healthcare workers and beyond, and then go to high-risk adults to achieve about 20% of proportionate to the population. And above 20%, once we arrive there, and we will one day, is then a decision for allocation will really depend on the epidemiology at the time, and also on the vulnerabilities. So it's not the epidemic alone or numbers, but also the vulnerability of a country. How can it cope with hospitalizations? So this is the state of vaccines today. As of 20th of February. So it's, by 20th of February, it was 76 days since first country started vaccinating. The first country to vaccinate, I think, was the UK. And 54 days since all EU countries received vaccines. 205 million vaccine doses have been administered. But here comes the equity story again. 83% of those have been administered in only 10 countries. At least 8 different platforms have been administered, but campaigns have started in 98 economies. Currently, as for now, the Pfizer mRNA vaccine is still the far most used vaccine, with 59 economies using it so far, followed by the AstraZeneca, then Moderna, and then Sinopharm, and then Gamaleya. And this slide shows you the proportion of the population vaccinated. And you can see here that Israel is clearly leading. Israel had a special deal, or was clever enough to have a special deal with Pfizer to negotiate a guaranteed volume in exchange for real life data. And as you've just heard, the vaccine effectiveness studies were published in New England Journal just yesterday, and they look extremely good. High proportion also now in the United Kingdom, in Bahrain, in Chile, in the US. I'm sad to tell you that I live in Switzerland and we are below 3% still. So, and I've not been vaccinated. I want to get vaccinated. I have no access. And here again, just another map that shows the distribution, and that indeed the number per 100 persons vaccinated is highest, is as you can see, just not equitably distributed. We need to keep in mind though, the first vaccine only received EUL on the 31st of December. We are only about 2 months in, and there will be maybe not a good ending, but a better ending than this picture. So the EU listing that we've had so far, so that is the WHO emergency use listing, have been given to Pfizer vaccine and to the AstraZeneca vaccine in all its variations, and soon to Moderna. Very, very soon, probably in mid-March, within the next 10 days or 15 days, we expect the EUL to be announced for Sinopharm, the Beijing product from Sinopharm, and for Sinovac. In March or April, probably more April, it will be J&J. And in discussion is Gamaleya and Novavax, also for April or beyond. J&J, by the way, I think will be in March, by the way. So here is the timeline. To show you the ambitious timeline. So really the announcement of Kovac as the vaccine pillar was in June 2020. Within a relatively short amount of time, 190 countries agreed, expressed interest and signed off to be part of it. A lot of money has been raised for this. End of December, the first vaccine to receive EUL was the mRNA vaccine, which of all the vaccines, as you know, is the logistically most difficult vaccine. But as for today, we are really planning that in February, we would roll out. And then in April, by 12th of April, the ambitious goal is that every country will at least have received something. I do agree this will be a small drop in the big ocean, but the intent is there. And the good news is it has delivered. On the 24th of February, which is 2 days ago, the first shipment occurred via Kovac, and the country was Ghana. Here you see the current supply of Kovac. So you see that initially, February, we still have a very small amount, but then there will be an incremental, if not an exponential growth as vaccine supply become available, as manufacturing are scaling up, but also as more vaccines become available. The secured volumes is in green. The secured volumes as it stands today, and is subject to change, is now 1.6 billion doses by the end of December. But the aim is more than 2 billion doses by the end of December. So some in gray, you will see, are volumes that are still under active negotiation. Here you see the Kovac supply forecast by region. So in dark blue or purplish blue is Africa. So you will see that initially, it is important for us to show, the goodwill, but we have limited supply. But to show goodwill, you have, and dividing a limited supply. So you give small doses to countries, and then you increase the number of countries. And then so we hope that this will then increase by the end of this year to about 2 billion doses. But I must tell you, there's more to just shipment. There's also country readiness. And we cannot just say, oh, well, we now have the Pfizer vaccine, we're willing to give it to you if a country is not ready. So the pathway to vaccine use in a country depends on the regulatory authorization and very, very important, the import approval. There have been a lot of hiccups and delays and because of import approval. It does take time. Then the policy in use, the procurement mechanism, and the plan to execute the vaccine rollout. So what needs to happen and what is happening is it's either a WHO EUL or an EUA through a stringent regulatory authority through which Kovac then will decide to roll out the vaccine. So if a vaccine does not have an EUL or a stringent regulatory authority authorization, Kovac cannot distribute the vaccine. It then relies also on the state recommendations, of which I am strongly part of, how best to use the vaccine and all the policy recommendations that we issue. It depends on the COVAX deals and the allocations, but it also depends on the NDVP, the National Deployment Vaccine Plans, and the plans for country implementation. So basically, you have. Okay, thank you. So a country has to be ready. And so you have to submit a vaccine request form, and then you are assessed for your readiness, because we don't want to send vaccines and then we find out they're going to be wasted because they were not ready. This includes regulatory pathways, and it includes a whole issue around indemnification and liability. I don't want to go through these slides, but you show this is a standard reporting form that are collected from each countries with a long list of questions, from regulatory issues to planning coordinations. What plans do they have about the funding? Because remember, Kovac only funds the vaccine, but not the logistics. The supply chain, what do they do about wastage? The health resources, is training in place? Is an AFI monitoring in place? Is a causality assessment in place? Is evaluation in place? And all these issues. And we have learned over these months where WHO and hundreds of people through Gavi, etc., and Kovac have worked with each single country, more than 190 countries, to get all this paperwork done, that the main areas of problem is often the supply chain and waste management, that they do not have enough details on initial vaccine allocation, so their prioritization map, a roadmap was not developed. They may not have a detailed cold chain plans, vaccine safety, communication plans, how they will investigate AEFIs, causality assessments, whether they're in place or not. So all these issues needed to be sorted out with every single country, and explains why we need some time before the COVAX could work out. And this is my second last slide. What we've now developed at WHO is a vaccine introduction toolbox. It's a repository for resources and training documents that is accessible in easy language, in different languages, to all countries, to help them prepare the rollout. And it will be updated as more information comes out. This is publicly available. Please have a look at the Toolbox slide desk. It's really very interesting. A lot of guidance, tools, and training material. In summary, different platforms with different vaccine characteristics have also different trade-offs. And in the near future, we need to talk about how best to use which vaccine where. Currently, vaccine supply is the biggest hurdle. The first lessons on the vaccine impact will clearly come from Israel, that is currently leading in high vaccine coverage. The good news is Kovac has started distributing as of yesterday. We will need a higher vaccine coverage, but we know if we really focus on those at highest risk, even if you only receive 20% global coverage, but 80% coverage of high risk group, we will have gone very far. Thank you for your attention.
Thank you so much for your messages, Doctor. I think that you really bring a very good perspective of what's going on from SAGE decision-making and to COVAX deployment. We really appreciate your participation. We now move, thanks to the technology and to the pandemic. From Switzerland, we go all the way to Africa, and we're going to be listening to Professor Stanley Okolo. Professor Okolo is an obstetrician and gynecologist, and is the Director General of the West African Health Organization, WAHO. He graduated from the University of Nigeria, had a postgraduate medical training in Nigeria, United Kingdom, and Canada, and spent the vast majority of his professional career in England before being nominated in March of 2018 as head of the WAHO and one of the Nigeria statutory appointments to the Economic Community of the West Africa, ECOWAS. An award-winning leader, clinical academic, and executive coach, Professor Okolo has had key regional and international leadership roles in healthcare, academic partnerships, and professorships and professional organizations. He has a PhD from the University of London, a professorship of the University College London, and numerous scientific publications to his name. At WAHO, Dr. Okolo has led a transformative agenda focused on 5 thematic areas: maternal and child health, pharmaceuticals, quality standards, communicable and non-communicable diseases, and health information. Dr. Okolo advocates using constructive disruption to accelerate health improvements and believes that to be successful health intervention programs in developing countries should address the wider issues of health and well-being, as well as illnesses and diseases. Dr. Okolo, it's a pleasure to have you with us here and listening to the African voice from you and understanding what's going on with vaccines in that region. Thank you so much, and the screen is yours, sir.
Thank you very much, Francisco. And actually, the pleasure is mine, because listening to the 2 previous speakers, I have learned a lot. And really, it is a listening and learning occasion for me. May I share my screen? And I will simply here talk about some of the issues that we have in West Africa and what West Africa Health Organization is all about and what we are doing in this part of the world regarding vaccines. Now, as you know, the West Africa itself includes several countries, but not all of them are part of the West Africa Health Organization, nor the ECOWAS, which is the Economic Community of West Africa States. So geographically, you may consider Mauritania and Cameroon as part of West Africa, but they are not part of the Economic Community of West African States. Rather, we have 15 countries, 8 Francophone countries, 5 Anglophone countries, and 2 Lusophone countries who speak Portuguese. That's Cabo Verde and Guinea-Bissau. The population is about 380 million, 390 million. And we have, if you look at the whole of Africa, we have about the largest regional population. And my outline of my talk is going to be talking about what do we do at West Africa Health Organization, what is the current state of the pandemic in West Africa, and what are the issues regarding health, the COVID vaccine. This is an organization that arose out of the merger of a research institute that was covering 8 Francophone countries called the OCCG, is Francophone Organisation Contrôle de Pandémie, Grande Epidémie. So that is the research institution. Many people may have been aware of some of their publications in the 60s regarding malaria and anti-malaria resistance or anti-malarial drug resistance. And then in 1972, there was an Anglophone organization which was mainly set up for postgraduate training and standards. And the West Africa Health Community that was based in Lagos and the OCCG that was based in Burkina Faso, Bobo Dioulasso, were the 2 organizations that in 1984 were merged to form the West Africa Health Organization. West Africa Health Organization received its authority to operate from the heads of states in 1987 when they agreed the protocol, and by 1998 they agreed that it will be headquartered in Bobo Dioulasso, which is the 2nd city of Burkina Faso. Incidentally, I'm speaking to you today from Abuja in Nigeria, where you have the headquarters of ECOWAS, but also because of COVID-19, we have established a regional distribution hub here in Abuja. The West African Regional Center for Disease Control, which is an agency under WAHO, is also the hub of the Africa CDC and is based here in Abuja. And WAHO, the first Director General, started in April 2000. So the organization, although it's been in existence for 30-something years, actually has been operational for 21 years. This summarizes the objective of the organization as set up by the heads of state, the 15 heads of state working together, set up an organization to drive harmonization, pooling of resources, and cooperation with one another and with others. Gives us an open mandate to work collectively with whoever is involved in health promotion so that we have a collective and strategic combat against the health problems of the region. Our priority areas in recent years are over 5 areas, and you mentioned this in your introduction, and really the one that concerns us during the pandemic is the prevention and control of communicable and non-communicable diseases. One of the things we have, however, set ourselves is that across all priority areas, we must have some cross-cutting themes. How do we build capacity in the region? How do we discharge our mandate of regional integration, therefore strengthening networks across the 15 countries? And how do we sustain our health programs? Having an eye to ensuring that our programs have a population impact, that we can have measurable outputs, and that we can also do some research from time to time regarding them. We had the first case of COVID-19 in our region in Lagos on February 27th. Since then, 27th, of course, last year. Since then, in the ECOWAS region, we've had about 384,280 cases cumulatively, of which 4,927 have died. And at the moment, with the second wave, we have about 41,065 active. Having said this, let me immediately put to for your attention the fact that we have, as WAHO, have sponsored, of course, collectively with all our partners, we have been promoting but also sponsoring and championing some community screening so that we understand what is really the actual prevalence of COVID in our areas, because we're not testing as much as we would want to, and we're not testing as much, of course, as Western countries. One of these published this week, and it was done in Nigeria. And in some of the states in Nigeria where antibodies, rapid antibody tests were done, they found antibodies to about 23% of population who were tested in house-to-house neighborhood schemes. In some states, 7%, in some states, 19%. So we can actually say that although our incidence is looking at about 1%, if you like, it is actually much more than that in terms of the prevalence within the region. This is what is happening on our 7-day rolling average, both for cases and also for deaths. You can see that during the second wave, we had a higher number of cases on the 7 days rolling average, also higher number of deaths. It would appear in our region, as at yesterday at least, that we are now having a diminution in terms of the cases. We are now, the second wave, we've passed the peak, it appears, and is going down. We at WAHO are tasked as an intergovernmental organization. We are set up by the heads of state. We are a governmental organization, so we are intergovernmental. But we are therefore charged as almost the regional health ministry, if you like, but there is nothing like that for the region. Almost like you have an EU health desk for European Union. And I know that there's also PAHO, and there are also other regional bodies who have similar. And so what we do within, or what we have done during the pandemic was, number one, to try and agree a regional strategy. And we did that even before we had the first case in our region. On the 14th of February, 2020, even before it was declared a pandemic, immediately after the declaration of COVID-19 as a public health emergency of international concern on the 30th of January, within 2 weeks, we convened the ministers. That's one of the things that WAHO can do. We convene ministers, we convene governments to come together to agree a process. And we had this regional thing. We agreed on a concept note, we agreed on a regional costed plan, we agreed on increased surveillance along our borders, we agreed on what we should do and how it should be done. That has continued with some success in varying degrees. And of course, you know that whenever there is a crisis, then you have the challenge between sovereignty and regional integration. But far and wide, I think it has really worked well in terms of the approach. Then WAHO itself set itself up to try and raise funds, resource mobilization, and we did quite a lot. We raised a significant amount of money, including internal and external funds, with which we not only supported countries with COVID-19 materials, pooled resources, pooled purchase, and critical medical supplies, PPEs, diagnostic tests, so that we are able to get high quality materials, even when the global supply chain was disrupted. We also set up online training because it became obvious that with the borders closed, the rapid response team which we have, it was not as easy to deliver them to countries of highest need, but also all countries had a need. However, we needed to have a surge capacity, and in order to have the appropriate surge capacity, we had to train them, and we set up a lot of online training. We also then had countries that had specific issues. So for example, at the beginning, Senegal had issues with having to identify enough contact tracers and enough public health response. What we did was to give them some financial support so that they can release some of the public health physicians that were not in the government or public sector within Senegal to support this. And this happened across all the, so Senegal is not alone. Some of the other countries. How many minutes?
10 minutes, sir.
10 minutes. Thank you so much. That's excellent. Thank you. And so I come to the last part of my talk, which is access to COVID-19 vaccines in West Africa. And I think the first two speakers, that's why I said I'm really here to learn. The first two speakers have already talked a lot about this, and I think Annelies has actually given my talk. Because the first thing we have to say is that what are the sources of vaccines for us in West Africa? There are 4. Kovac, which Annelies has already gone to detail about. The only good news that is coming, well, not the only, sorry. One of the other good news that is coming out of Kovac, apart from the fact that they have started distributing, is that they have secured more funds than they were anticipating. And in fact, they are also able to give more than the 20% that they had pledged. So that is good news. It's coming out of Kovac, and we're really pleased about that. We have an African Union-led initiative called the AVAT, African Vaccines Action Task Team or Acquisitions Task Team, which again in itself is trying to see how we can plug some of the gaps so that we can get up to at least 50 to 60%. Let us not be in any illusion. What we are really looking for here is to support, in the first instance, the priority target groups. And that's that 50 to 60%. 50% depending on how you calculate it, 60% depending on demographics. The third source is what we are now doing, which is a pooled procurement through ECOWAS and WAHO, which is where we pool funds, also some of them from the countries, and use a multiplicity of sources to actually identify vaccines and make sure that we do have them. And then, of course, the final is the bilateral arrangements that individual countries are making in individual areas. As already been said, the first vaccine that has been available is the one that is least logical or least practical for us in Africa, which is the Pfizer vaccine, because we don't have liquid nitrogen storage facilities that are widespread for us to use that. However, a lot of deals have been done, as you can see, both through the Kovac and also the African Union, but also individual countries who have signed some deals at various prices in order to have vaccines for their country. But this was also a slide that I saw Anele put up. The only problem is that I think your slide you removed Morocco, or I didn't see Morocco there. Morocco here is the only African country that you can see in this, and we're talking about vaccine permeation of 0.75%. This actually should sum up every presentation or all the other slides I have to make here, which is, why is this so? And how do we try to address it? Because global health security is such that even if we have 100% population permeation in some countries, until we have significant in others, nobody is safe. And then we have been working on this in our country to think about how we, in our region, to think about how we get vaccines for the priority groups, the different countries that make up ECOWAS, and how we've calculated what we should need to do in order to have the outstanding 30%, if we only got 20% from Kovac, how much do we require? And even if we're buying the AstraZeneca at an indicative cost of $4 per dose, how much do we require for that, which is coming up to about $1 billion. To date, we have to say that actually the picture keeps changing. Of course, as everybody knows, the vaccine picture changes every day or every week. We think that we will be in a situation that we will require to raise about $1 billion at $4 each to meet the deficit. We will not get that through Kovac, we will not get that through the AVAT or the AU platform. We will have to look for other areas. It is also important to note that using the WHO tool, which is the VIRATS tool, in terms of scoring our countries, ECOWAS countries are not really doing very badly. We are at about 57% score on a composite score. Of course, this hides the fact that we have something like Cabo Verde and Ghana and some other countries who have a higher score than some of our other countries. But we are moving on this. On the African platform score, we think we might get up to 80 million vaccines, additional vaccines from the AVAT for West Africa. But that then again leaves us, because we're 240 million short, in order to reach 50%. We're not even talking of 60%. So today, what do we have? We have some countries in Morocco, Algeria, Egypt, South Africa. Ghana, as you have heard, as at 2 days ago, received 600,000 from the Kovac. Cote d'Ivoire today is receiving 500,000. Senegal has had a donation from China and started. Guinea were involved in the Russian Sputnik trial and received 500 doses. We're expecting some doses to start arriving in Nigeria in the next week or two. But that is really a drop in the ocean compared to what we require. We have had strategic discussions through the ministers to try and progress on this. And we've been talking about this since June 2020. The heads of state themselves have, having surveyed the landscape, decided that they have to set up a vaccine revolving fund. And that what we should aim for is not only availability in the short term for those remaining percentages, but manufacturing in the medium to long term. And we have 3 manufacturing outfits that are nearly ready, one in Senegal, one in Nigeria, and one in Ghana, to undertake fill and finish in partnership with some others who already manufacture, so that we don't have to import from Serum Institute in India, and we can immediately start doing this. And that is similar to what Egypt is doing with Sputnik. We have some challenges, however, and this is my penultimate slide. The logistics issues remain issues. When you get the vaccines, then you need the syringes, you need to make sure you have the cold chain. We do have some countries that are, like Nigeria, for example, we had just come out of the polio, had just been declared polio free, still has a lot of the vaccine landscape, the cold chain and everything that they used for maximum vaccination for polio. But we also have expanded program on immunization in other areas. The second challenge is the challenge of vaccine acceptability. I mean, in developed countries, you call it vaccine hesitancy. Sometimes we call it, vaccine. It's not really anti-vaccine. It's anti-vaccine in a few areas, but it's just the question of hesitancy regarding vaccines. A recent study in Senegal showed that this was only about less than 60% of people would accept vaccines, more than 40% would not. And those who accepted there is no sex or gender difference. Males and females are same intentioned. The older adults appeared to be more those who would accept vaccines. And therefore, in conclusion, so that I do not overrun my time, thank you so much, Francisco and FIU, for inviting me on this platform. I'm here to learn so that also we can see how we can support our countries. The need is, of course, very high here. The political will is there, but we do require more funding. The greatest inequality, I think, is the non-availability of vaccines. And that slide, that table that showed that Israel has already vaccinated 88-point-something% of their population really shows its stack. And it's not really only a question of paying for the vaccines, but if countries have made deals for 3 to 4 times their population of the vaccines, really that makes the vaccines not available for the others. And it's good to see that after the G7 meeting, in that this is shifting. This is now shifting, and we are hearing pronouncements from England, pronouncements from France, and I think Canada also, that they're going to shift some of their vaccines. Work is in progress to improve availability through partnerships and collaborations, not just us talking to each other in South-South, but also North-South, to see how we can get. And then, of course, we do have the challenges of logistics and acceptability. Thank you so much for having me. I hope I kept to time, and I will wait for the discussions. Thank you so much.
You did keep time, Dr. Okolo. Thank you so much. Merci beaucoup. Obrigado. I really appreciate your participation in, today and bringing the voice of Africa, some voice that is not listened to very widely in the world globally with the pandemic. And it was very nice to have you today.